Welcome, Dr. Akshay, another good friend of mine, an ace head and neck surgeon. Was working in HCG for quite some time. Very good robotic surgeon, and now he is heading the head and neck department at Psych Care Hospital. He's going to talk on a very important topic, that's on trismus management. Again, a dreaded complication. We have had orocutaneous fistula, and then we have had infratemporal fossa management, and trismus is another very important topic, very relevant to us. The stage is all yours.
Thank you, Girish, for the introduction, and I'd like to thank organizers for giving me this opportunity. So, over the last 1 or 2 decades, there have been significant advances in the surgical front, the reconstruction front, radiation, chemotherapy. Obviously, we are having patients who are living longer, and they carry with them the package of morbidity, and trismus is one such morbidity. So, a good mouth opening, our mouth is a gateway for our entire human body, and a good mouth opening plays a very, very important role in majority of functions. So, daily functions like nutrition, chewing, making into a bolus, and then facilitating an involuntary swallow, breathing without aspiration, speaking, maintaining a good oral hygiene, and especially in follow-up, a good mouth examination is only possible when there is a good mouth opening. And in situations where we need to place dentures, prostheses, a good mouth opening plays a very, very important role. Yeah, next slide. So in oral cavity, we should understand the normal anatomy. If you look at our oral cavity, the buccal mucosa is pink, very soft, elastic tissue, and is composed of 3 layers. The thick non-keratinizing epithelium, which is elastic, which stretches, that way it facilitates good mouth opening. Deep to that, there is a lamina propria, which has type 1, type 2 collagen elastin, which is responsible for the elasticity. And deep to that, you have the neurovascular bundle, lymphatics, and deep to that you have muscles, and the pliability of these tissues are very important to achieve a good mouth opening. With regards to the muscles which helps us assist in opening and closing of the mouth, the temporalis and the masseter muscle helps in closing the mouth, and the lateral pterygoid, the medial pterygoid also helps in assisting to close the mandible. So the lateral pterygoid is one of the major muscles which helps in opening of the mandible. The temporomandibular joint is a very important joint. It's a very complex joint, and it is there are muscles and joint. It's a hinge type of joint which helps in gliding side to side movement as well as opening of the joint. So you can see how the lateral pterygoid assists in opening, and then the joint hinge movements which is responsible. The pliability of the tissue, the joint movements, all of these are very, very important to assist in the movement. Next slide. So trismus is when the mouth opening becomes restricted. There are different ways of classifying this trismus. There are numerous classifications. Next slide. So whenever there is a compromise on the mouth opening, all the enumerated functions of this mouth opening will get disturbed. As a result, it results in poor chewing, nutrition, difficult swallowing, nutrition, aspiration, need of tracheostomy, pneumonia, and so on. Affects talking, affecting quality of life, inability to maintain oral hygiene, resulting in social stigma, difficult in examination, especially when a patient in follow-up present with a recent trismus. We also have to look at the possibility of recurrence, and obviously reduced mouth opening will impede placement of the prosthesis. So, next slide. So there are numerous classifications for trismus, but this criteria enumerated by this group, where they looked at the functional cutoff of trismus, and they based on functional criteria, and they found that a mouth opening less than 35 mm is where it impedes functional, it causes functional impairment. So trismus is quite common at presentation, and Tata group had looked at this incidence of trismus, and the incidence of trismus is variable from in oral cancers ranging from up to 80%. And in our population, obviously because of the submucous fibrosis, the trismus incidence is quite high, and the reported incidence in the large series of 400 patients was around 80%. So what are the reasons for trismus? The reasons of trismus is the most common, as we discussed, submucous fibrosis, especially in the buccal cancer. When the elasticity of the buccal mucosa gets hampered, it leads to submucous fibrosis. The other reason is the extension of cancers to these masticator spaces, whether it's the masseter, medial pterygoid, lateral pterygoid, and so on. And post-treatment, whether it's surgery, radiation, chemotherapy, all of these causes some kind of fibrosis, and that leads to trismus. And pain, of course, will lead to trismus as well. So what happens in submucous fibrosis? Submucous fibrosis, as we know, is caused because of betel nut chewing. There will be diffuse whitish area of submucous fibrosis resulting in chronic inflammation and change in the collagen. There will be excess collagen deposition and leading to local inflammation, increased collagen in the lamina propria, and there will be tissue degenerating changes, and even the muscle gets, deeper muscle gets fibrous. So when the Tata looked at the possible predictive factors for trismus, submucous fibrosis was one of the major factors in causing trismus in the preoperative settings. So when they did a multivariate analysis on this group of patients, they found that the adjuvant therapy as well as the submucous fibrosis were two important factors which eventually resulted in the trismus in the long term. So even, all the buccal mucosa patients generally kind of present with about 30 to 40% of patients with a buccal cancer usually have trismus, and whatever coronoidectomy, good reconstruction, still has to go through a rigorous physical therapy to achieve reasonably good outcomes. So again, just a case of a buccal tumor, which was a composite resection done. We did a ALT flap. Even then, the mouth opening still remains, without taking adjuvant therapy, still remains dismal. So in addition to the site of the cancer, the size, the stage of the tumor, the extension of the tumor, also the location of the tumor, whether it's a posterior located tumor versus anterior located tumor, makes an impact. So when you look at the site, the gingiva buccal sulcus tumor have a higher incidence of trismus, probably because of submucous fibrosis, also because of the involvement of the posterior masticatory space. So when they looked at the mouth opening in the patients in relation to the location, they found that the posterior located tumors, the maxilla, mandibular, involving the masticator space, obviously has had a lesser mouth opening compared to that of the tongue and the floor of mouth tumors. So whenever there is no submucous fibrosis, then we are able to with good reconstruction. There is no need of aggressive mouth opening exercises in those situations. However, when you are dealing with a situation where you have a recurrent patient with post-treatment, despite doing a good lining, there will be issue of trismus because of the fibrosis associated with the previous treatment. In chemotherapy-related trismus, it's mainly because of pain. Usually it's self-subsiding with the course of antibiotic and good oral hygiene. But the management here is mainly with exercises. So exercises, prevention is the best thing, and exercises is the most important to achieve sustained good mouth opening exercises. The variety of methods through which you can achieve this mouth opening exercises. Whenever the mouth opening is very, very less, you tend to start with the wooden spatula and stack a wooden spatula in between, so that once we have a reasonable mouth opening, then we can start with the hister and then gradually move on to the terabyte. The terabyte is proven to have a best compliance in terms of ease of use and so on. But however, to achieve that, to be using this Heister, you should have a reasonable good mouth opening. Initially, we start with the wooden tongue spatula, move to Heister, and then go for the terabyte. With regards to how to perform this, there have been numerous literature, different ways of doing it. There is no single way of doing it. But it's important that you have to do multiple sessions in a day with multiple repetitions. The duration of the stretch should be at least about 15 to 30 seconds till they get a pain. And the duration of the therapy should last for about 2 to 12 months. The most important thing is to have to start the therapy early and to be do it on a regular basis. So this is a small video just to show how we perform the Heister. The patient they'll do it themselves. It's important to look for the tooth which are strong enough to place this. Otherwise, you may end up breaking the tooth. And then slowly, gradually open up this Heister until the patient experiences pain. At that point, you wait for some time for about 15 to 20 seconds, and then do this for multiple repetitions and with multiple sessions. Important is to continue for a longer duration of time. So these are the patients who have been reconstructed. We have done a marginal mandibulectomy. We put in the radial forearm flap. But patient with submucous fibrosis, it's always a challenge despite doing good reconstruction. So in terms of radiation-induced trismus, there is some literature showing that the pentoxifylline tablet is said to decrease the trismus. This was one study which showed about increase in the mouth opening for about 4 mm. But again, these are all a few not very strong. We don't advocate this, but this is one of the medications which we can try. In submucous fibrosis, obviously, when a patient with a submucous fibrosis comes to you for getting his mouth open, it is very difficult to give the best outcome. So generally what we do is we try conservative measures, and there is some evidence showing that injection of triamcinolone in intralesional injection with exercise therapy is found to show some improvement. This is one of my colleagues during my MS times who has done his thesis and he got it published. We showed a significant improvement in mouth opening, and we do it initially when the patient with submucous fibrosis comes to us. So whenever you are attempting surgery for a submucous fibrosis, it is better to attempt submucous fibrosis for patients who have mouth opening less than 2 mm. So studies have shown that whenever you have mouth opening less than 2 mm, then when you do surgery in these cases, we do get some benefit of about 1 centimeter on a long-term basis. So this is, we can use an insulin syringe. So we use a 40 milligram triamcinolone. We can also, we can use it mixed with triamcinolone with local anesthesia so that the pain will be less. So we give intralesional injection, and this is followed up with the exercises. And we do 2 sessions in a week, and we continue it for 12 weeks. And they get an improvement of about 1 centimeter or 1.5 centimeter at the end of 6 to 12 weeks. So coming to the surgical management now. So any trismus, whether it is submucous fibrosis or cancer with submucous fibrosis, there are few things which we have to look at in addition to oncological clearance. Whenever there is fibrous bands, we need to release those bands obviously away from oncological margin. And then we have to do a myotomy. So the myotomy, most important is a coronoidectomy with temporalis. And after these releases, you need to line this tissue with a skin lined or a mucosal lined flap, and post that we have to start with aggressive therapies. So as I told, coronoidectomy, in coronoidectomy, whenever the mouth opening is less, coronoidectomy as a treatment option has been useful in mouth opening less than 20 mm. It has been, after maximal physiotherapy fails, it has been found to improve the mouth opening. So how do you do the coronoidectomy? So especially in situation of trismus, reaching the buccal, the area of coronoid is challenging. So how do you do it is you look at the molars, and then you have some spatulas, the tongue spatula with optic light carrier, which helps us to give some illumination in that area. Other way is just follow the posterior molars, run your cautery on the body of the mandible, and then follow it upwards, and that leads you, there'll be a avascular plane that will lead you to the coronoid. Once you have done that, you can use this kind of spatula to kind of strip the tissues around it, and once you have exposure of the coronoid, then you can either hold the coronoid with a cocker and then use a saw and cut the coronoid. Certain situation it might be difficult. In that situation, what we do is we cut it and leave the coronoid to slide upwards. So if possible, it's better to remove the coronoid and remove the part of the temporalis, and do it bilaterally if it is done for trismus less than 2 centimeters. And then you use a buccal pad of fat or some local tissue around it to line it so that it doesn't fibrose and worsen. So this was one of the article which I just looked it up. It was from the Taiwan group. We looked at two approaches when you're dealing with buccal cancers. So one, their traditional approach was go and do a wide excision with line them with the flap. In the other approach, what they did is they did a marginal mandibulectomy. Along with that, during the oncological resection, irrespective of oncological reason, they did an ipsilateral coronoidectomy and a myotomy. And with this, they have achieved a good mouth opening in a long-term basis. So we do a similar kind of situation, similar way. Is there a video in it? So this is how we do it. So this is a buccal cancer where for oncological reasons, actually we didn't have to remove the mandible, but the mouth opening was about 1.5 centimeter. So what we do regularly in this situation is we do a coronoidectomy just with the intent to achieve good mouth opening post-operatively. So we expose the temporomandibular joint area, identify the sigmoid notch, and then once we have a good soft tissue control, then we go ahead and do the vertical and the horizontal cut, just like a marginal mandibulectomy. And this helps us to achieve reasonably good mouth opening. So that's the horizontal cut being given. So you need to make sure it's bicortical. And then the last part, whenever you can just chisel it out. So this coronoidectomy helps us achieve a good mouth opening post-op. So that's the same patient. So this patient started with a one-finger mouth opening with a retromolar disease with submucous fibrosis. We had put an ALT flap. There is a bit of gaping in the palate. 1 to 10.
1, 2, 3, 4, 5.
So without submucous fibrosis, it's not a challenge. You can just line it with a good flap, and reasonable good outcomes can be achieved. So another most important thing is when you are doing large composite resection, it's very important to choose your flap correctly. So in this case, it was a lady with a large breast. So we did a bipaddled PMMC. Unfortunately, the skin lining failed. So whenever there is a issues with the lining of the flap, this patient didn't have a submucous fibrosis. The patient had significant financial constraints. So we didn't give an option for a free flap. So here, unfortunately, the inner skin paddle failed, and the patient ended up with a bad trismus. So all flap, if feasible, you need to salvage this flap and put a new flap for the inner lining to achieve good outcomes. But however, in this situation, we just managed to discharge her, and she's able to eat and drink now. But then there is a significant morbidity of trismus. So you need to be very, very careful while you are choosing your flap for large composite defects. Is very important. It's better to choose a free flap than trying to do a regional flap. So the advantage of free flap is that more extensive defects of the buccal mucosa and mandible with good reconstruction. So we can achieve next. So we can achieve good outcomes. So the important thing here is that we need to have a very good lining, and wherever, even if situations where we end up in a mouth opening, the inner skin paddle getting devascularized for whatever reasons, if feasible, it's better to put a newer flap lining the oral cavity, because this will relieve long-term problems. So to conclude, therapeutic strategies once trismus is established is difficult. Prevention is always better. It's very important to do an appropriate reconstruction and deal with the submucous fibrosis during the operation. And followed by this aggressive exercises has to be done. Only then we can achieve good outcomes in trismus. There is no point doing a reconstruction and not rehabilitating them. If you do that, then on a long term, we won't have a good mouth opening, and that will not improve the quality of life eventually. Thank you.
Thank you, Dr. Akshay, for this fantastic presentation on trismus, which is always a challenge for all of us, and especially because we have a concurrent tumor and SMF on the other side. How often do you release the other side, non-involved side, with SMF and put something like a buccal pad of fat and coronoidectomy on the other side?
So whenever the mouth opening is less than 2 mm, so that's where we would go and open up the opposite coronoid, or if there is large dense fibrotic bands, which is there in the bilateral buccal mucosa with a limited mouth opening, roughly about 2.5. Those were the situations we would do bilateral opposite side coronoidectomy.
And
or in situation of submucous fibrosis, obviously you have to release both.
Very important that patients do aggressive physiotherapy, and that will continue for at least about a year. Otherwise, invariably we end up with trismus, with the fact that a lot of these patients also get radiation fibrosis. So that's a very important take-home message which you gave.
Regarding that exercises, what you're saying, sir, that video what he had shown, Dr. Akshay, it was very nice. Sitting with the patient, making him motivated. The minute they have the pain, they'll stop it. But when you're making them to do it, you explain them, even you have a pain, just count for 5 to 10, then again stretch it. That makes a lot of a difference in the rehabilitation of the patient. Yeah. Sitting with the patient, making them do is a very
absolutely. I think that humane factor of giving them that other extra,
in that the history is metallic, so you need to have some cushion placed.
Yeah, you need to put a rubber. I mean, one of the things which we see also is the fact that you break the teeth, and it's important that not to extract all the teeth. If you're anticipating that there is going to be a bit of trismus, please leave some of the premolars, not the molars, because that becomes very, very difficult to extract later on. But at least from premolar onwards, I think if you can retain the teeth, at least on the other opposite side, that will help in using the hinders. In fact, better than hinders is actually the wooden spatula. I've been, recommending for all our patients wooden spatula, because that you can stack it up and it's less damaging.
You can do it bilaterally as well.
Absolutely. Absolutely.
So, just one point I want to make is that when the patient has severe trismus, when you have to do a bilateral coronoidectomy, of course, on the side where you're operating, the coronoid axis is there. But on the opposite side, sometimes it becomes difficult to gain access from the opposite side as well, because of decreased mouth opening. The coronoid is placed in a higher up. So in that situations, what we tend to do is raise the nasolabial flap. Anyway, you need a flap to be interposed in between once you have released the bands. Once you raise the nasolabial, through the bed of the nasolabial flap, you can access the coronoid process and do a coronoidectomy and put the flap inside the oral cavity as well. So when the mouth opening is less, the coronoid process can be easily accessed through this way.
I think just doing a coronoidectomy itself is good enough, because the moment you do an osteotomy, the temporalis just pulls it up, and it's extremely difficult many times to even retrieve the coronoid.
The point is that, of course, it's not for retrieving the coronoid, it's that we have to identify the notch and just try to stay anterior to it. Without which we may end up transecting the entire
Condyle,
condyle as well. So in that situations, when we are struggling to do it intraorally, we are not able to do it properly. And anyway, we have to put a flap in there. Sometimes a buccal fat. The other point is in patients with such severe trismus, there is hardly little buccal fat also left, so which cannot be utilized properly. So anyway, we need a flap. You could just raise a nasolabial, go through the bed, do the coronoidectomy, and just put the flap. It makes life a bit easier.
If there are no questions, I think it's time for lunch. Thank you so much, Akshay. Very nice presentation.